Perfect. Then you can just enlarge it when you're ready.
All right, everyone can see my slides now?
Yes.
Yes.
Yes, okay, perfect, thank you. All right, so, introduction to adrenal disease was the topic given to me. As you know, it's a very long topic, but I've only picked up 3 topics that I want to discuss so that we can focus on rather than, talking about everything. These are the 3 things I want to focus. I think these are important. We, as primary care physicians, family practice doctors, hospitalists, we see these things commonly. So that's why I will be talking about these. So the first one will be adrenal incidentaloma. It's extremely common, and the incidence is increasing because so many people are getting CT scans. So just the workup of, what should be the approach as a primary care physician. And then commonly we see patients coming to the clinic and talking about their weight gain, and they have read about on the internet, and they're concerned about if the weight gain is related to the adrenal problems. And then lastly, if hypertension, when should we consider hypertension, which is extremely common, if that is related to the adrenal gland. So briefly, I'll talk about what adrenal gland is. Most of us know that this is a gland sitting on top of the kidney. On either side, there's a right adrenal and the left adrenal. And although adrenal gland is one organ, but it really functions as 2 different organs. The outer portion of the adrenal gland, which is called the adrenal cortex, makes 3 different hormones. So it makes your aldosterone, which controls blood pressure and sodium retention. The middle layer, zona fasciculata, that controls the steroid production. And the innermost of layer makes the adrenal sex hormone. So basically, hypertension hormones, steroid production, and adrenal sex hormones are produced by the adrenal cortex. And the innermost part of the gland, which is the adrenal medulla, that makes the stress hormones, epinephrine and the norepinephrine. So basically, 2 different portions, outer portion and an inner portion. The outer portion makes the blood pressure hormones, steroids, and the sex hormones, and the inner portion makes the stress hormones, epinephrine, norepinephrine. All right, so let's initially talk about adrenal incidentaloma. That's the first part of the talk. So what I'll present a case. It's a case that I've seen in the clinic, and then I will discuss what the management or what the approach should be when you see these kind of patients. So 42-year-old female who was seen in the ER because she was having some urinary symptoms and low-grade fever. Her symptoms started after an IUD was placed 2 weeks before her presentation. And she went to the ER, so there was a concern that the IUD might have been displaced or came out of perforation. I think they were concerned about. So correctly, a non-contrast CT scan was done to see if the IUD is still in place or if there is perforation. The report came back and it showed that the IUD was in place. However, it showed this adrenal nodule. So this is on the right side, and you see this here. I'm put an arrow here. So this is an adrenal nodule. So she went in with one complaint, and they wanted to rule out to make sure that the IUD was in place, but they ended up finding out something totally unrelated. Most likely that was not bothering her at the time of her presentation. So that is an adrenal incidentaloma. So we will talk about what is the definition, how common it is, and most importantly, once we find it as primary care physicians, as hormone doctors, what are the next steps that we need to do. So the definition of adrenal incidentaloma is an adrenal mass that is discovered on imaging performed for other reasons, which are unrelated to the adrenal gland. So for example, this patient went in with concern that the IUD might have been displaced or has come out or perforated the uterus. But we found that was in place, and the radiologist commented on something totally unrelated. So that is the definition of an incidental finding or an incidentaloma. How common it is, the first thing is most adrenal incidentalomas, when we see these, they are mostly, not always, but mostly benign. And we will discuss as to what are some of the features that will increase the likelihood of the benign findings. Most of them, great majority of them, about 95% of them are non-functional. So they are just sitting there on top of the adrenal gland, not making any hormones. And it's common. About 9% of the patients have it. So when they go to the ER and get the scans done, so the chances of finding an adrenal incidentaloma or any incidentaloma in different organs is very high. So 9%, that's a lot. And again, more and more CT scans are being performed. So we're going to see more and more adrenal incidentalomas, plus the population is aging over a period of time. And we found, these adrenal incidentalomas increase with aging as well. So this is very common, and we'll see this. So the first thing is, when we see this, or when we are seeing these patients, or in the ER, when we have this question about the adrenal incidentaloma, is to see what kind of scan was done. So if the CT scan, which is the most common scan done, first thing we need to know if this was with contrast or without contrast. So if we see non-contrast, that means there was no contrast, no IV contrast or intravenous contrast was given to the patient. If a non-contrast, like in our patient, was done, this is very helpful because this will tell us how dense this mass was. Because the first thing we need to understand is how dense this mass is. And most incidentalomas are full of fat. So these are benign, and their density is actually less than 10 Hornsfield units. So that's the first thing we need to look at. What are the Hornsfield units on this adrenal mass? So what is Hornsfield unit? So these are named after this chemist actually who invented the CT scan machine, and his last name was Hornsfield. So basically what it tells us is how dense. So if you have a bone which is very dense, their Hornsfield units will be very high. Air, which has no density, will have extremely low Hornsfield units, and water has a Hornsfield unit of 0. So if we have a mass which is full of fat, that means it has less water. So their Hornsfield units will be less than 10. So it will be either 9, 8, 7, or in negative. So -5, -10, -20. So if we are seeing, if a radiologist reports Hornsfield units as less than 10 or negative, then that means there is no density in that mass, and it is most likely composed of only fat. And that's what we want to see, because this will tell us that this is a benign piece of fat that is sitting on top of the adrenal glands. So the first thing to know is what kind of scan was done. Was it a with contrast or without contrast? And then if it was done without contrast, then we need to know the Hornsfield units. So if you have a non-contrast CT scan and the Hornsfield units are less than 10, then this means that this is a lipid-rich adenoma, and that's a benign finding. That's what we want to see, so that we can reassure the patient then and there in the ER that, look, this is not a cancer. You don't have to worry about a malignancy. This is a piece of fat sitting on top of the kidney. Now, if suppose the non-contrast CT was done, non-enhanced or CT scan was done without contrast, and the Hornsfield units are more than 10, meaning there is some fat but not a lot of fat, then the next thing we should do is to get a CT scan, this time, however, with contrast. So give the patient contrast through the IV, and then calculate this, which the radiologist will actually do this for us, and they will tell us at the end of 10 minutes how much of that IV contrast was still retained by that mass and how much actually was cleared through that mass into the circulation. So if you have a washout contrast of greater than 60% at the end of 10 to 15 minutes, so meaning the contrast that was given is through the adrenal glands, more than 60% of this is a very good sign. This is a sign of benign growth. And that will mean that even the Hornsfield units are a little higher than 10, but the washout contrast is telling us that this mass is benign. If the washout contrast is less than 60%, then that is an area of concern. That is a concern. And then that mass needs to be followed up with either an MRI or a PET scan or a different thing, a different form of imaging. So when do we need to worry about these incidental findings? So there are two scenarios where we need to worry about them. Number one, a non-contrast, or without contrast CT scan with a Hornsfield unit that is greater than 10. So that means if the Hornsfield units are reported as 20, 30, 40, and so on and so forth, that means that the mass is dense. And after that, if we do a washout contrast and all the contrast, more than 60% of the contrast is still retained and not cleared by the adrenal gland. So that means there's something wrong with the vascular supply of that mass. It could be a cancer, a lymphoma, or something that is sinister and not benign. That is when the endocrinology, or you can send the patients for surgeons, but preferably to an endocrine, so that we can do the hormone assessment and see what kind of hormones this mass is making. So back to our patient that we had discussed initially. Again, she was 42, went in with some urinary symptoms. CT scan was done because to locate the IUD. Her Hornsfield units were -6, -6. So that means her mass is full of fat. So at this time, we don't need to repeat a CT scan with contrast. We have enough information that this mass is benign. We do not need to do any MRI. In fact, we do not need to do any other imaging study at this time for this mass, because we have the Hornsfield units, and this is very, very reassuring. So, however, if our Hornsfield units were more than 10, like 15 or 20 or so on and so forth, then we would have done a CT scan with contrast to better understand as to what this mass is, if it's benign or not, and then we would have seen the washout contrast. All right. So the first, once you answer the question if it's benign or not benign, based on the Hornsfield units, and the second question is this mass secreting anything? Is it making any hormones? Because even a benign mass can make certain hormones which can cause problems. So these, if a mass is functional, we need to answer the following questions. Is it making too much aldosterone, which causes high blood pressure? Or is it making too much steroid? Cortisol, which can lead to weight gain and fractures and so on and so forth. We will talk about it. Or is it a subclinical condition, meaning it is making slightly higher amounts of hormone, but not enough to cause a significant clinical manifestation, meaning they're having difficulty losing weight, their cholesterol is running high, they have some skin bruising, but not severe amounts of effects from the cortisol. So that's what we want to rule out when we have a mass which is benign. So aldosterone, if there's too much aldosterone production, then these patients will have significant history of high blood pressure. They will have hypertension, and especially hypertension at young ages. So they will be in their 20s and 30s and present with high blood pressure, which will be difficult to control with normal, general medications. What we do in this situation is we check this blood work. We check a potassium level, because their potassium levels can run low. We can check their aldosterone, which is the hormone that this adrenal mass makes, and also the renin level. And I will talk about these tests in the later slides, but this is something that we want to make sure, especially if they have hypertension and now they have this adrenal mass, to see if they are making too much blood pressure hormones, which is causing this problem. Now for subclinical Cushing, this is an easy test. I think once we have this adrenal mass, which is benign, the primary care physicians can easily order this test, and which will be very helpful and reassuring for the patients. Because again, more than 90% of these masses do not produce any hormones. So this is just a piece of fat sitting on the adrenal gland. So if the primary care physicians can actually do this test, this will be very helpful and very reassuring. The patient does not really need to come to an endocrinologist after this adrenal mass. So what we do in this test is we give a low dose of steroid pill, which is Decadron. And it's important that we only prescribe Decadron because it's not picked up by the SA in the morning. So we prescribe this medication, which is a steroid, dexamethasone, and the patients need to take it at bedtime, right before they go to bed. So if they go to bed at 10 p.m. or 11 p.m., that's when they will take this pill. The morning after, at 8 a.m., they will go to the lab and have their cortisol levels checked. And what we want to see is the following. When we suppose this patient has an adrenal nodule sitting on top of like our patient, we want to see if this is making too much cortisol. So what we will do is we will give the patient the steroid pill, and we are hoping that this steroid pill that we are giving will suppress any stimulation that comes from the brain. So this adrenal mass is on its own. And if this is a benign mass, but it is producing hormone, then without the stimulation from the brain, the cortisol levels in the morning will still be high if this is a functional mass. So again, the patient needs to take the pill at night just before bedtime, and the pill is decadron or dexamethasone. And then in the morning after 8 a.m., and this is important because the cortisol level peaks in the morning, and the patient will go to the lab and have a cortisol level check. Now, if there are some concerns that the patient has significant malabsorption or cannot absorb the pill or had some kind of stomach surgery like bypass surgery done, then it's a good idea to check the level of the medication in the system, the dexamethasone along with the cortisol. But if in a normal individual without any significant history of malabsorption, if you give a pill and check the level in the morning cortisol level, what we want to see is a cortisol level that is less than 1.8. So if we have a benign mass, if we have ordered a aldosterone and a renin level, and the day after the blood work, we do a dexamethasone pill at night and check a cortisol level, then we can answer this question if this benign mass is making any hormones. So just to summarize about the adrenal mass, adrenal incidentaloma, the following things I think we need to remember. First thing is, because a CT scan is the one that has made this diagnosis, we need to look at the CT scan first and make sure that if it's a non-contrast or a study done without contrast, what are the Hornsfield units? If the Hornsfield units are less than 10, then that means this mass is benign. It's full of fat, and it is nothing, we should not be concerned about it. If we don't have Hornsfield units, or the Hornsfield units are slightly more than 10, like 11 or 15 or 18, then we should do a contrast enhanced CT scan, meaning with IV contrast, and see what the absolute washout is at the end of 10 minutes. And the radiologist and the report will tell us about it. More than 60% of washout contrast, that means that this is a benign finding. So at that time, we can reassure the patient that this is a benign mass. It is a piece of fat. We don't need to worry about a malignancy. And then once we have answered this question, then we need to know if this mass is making any hormones. So to prove that, we will check actually the hormone levels. So if you have a patient and you know this is a benign mass because the Hornsfield units are less, then you can order the following tests. You can order potassium levels because sometimes their potassium levels are low. You can check their kidney functions, so creatinine, or you can get a BMP. We want to check an aldosterone level because that's one of the hormones that the adrenal gland make. We want to do a renin to see if the renin is suppressed. And we can check the adrenal sex hormones, which is the adrenal DHEAS. Once these tests are done, then we can prescribe this dexamethasone pill that the patient will take at night. And after taking this pill in the morning, the patient will go to the lab and have a cortisol level check. We are hoping to see a cortisol level that is suppressed. Now, it's important that we only prescribe dexamethasone for this test because this medicine, although it's a steroid, but it's not picked up by the cortisol assay. So when we check the cortisol assay, it's only body's, endogenous or body's production of the adrenals production of the steroid, and it's not affected by the decadron, but it will suppress the stimulation coming from the brain. So I think if we have an adrenal incidentaloma, even the primary care physicians can do this workup up until this point. And if there are any danger signs or if the levels came back high, then certainly at that time, endocrinology can be, the patient can be sent to the endocrinology. All right, and again, the values, I think the numbers to remember here is once you order these tests correctly are the following. Number one, after the pill, after the dexamethasone pill, if the cortisol value is less than 1.8, then this means that the mass is not making any excessive cortisol, and we don't need to see these patients because this is a benign mass. You need to follow these patients, maybe repeat a CAT scan in another year, and reassure the patient basically. And if the mass is not growing in size, then you do not need to repeat any CT scans after that. So that's the first thing. However, if the cortisol level is more than 1.8, then sure, the patient needs to come and make sure that this mass, this incidental mass, the benign mass, is not making any excessive hormones, and then endocrine needs to be referred. If there is hypertension and your aldosterone level comes back high, more than 10 nanograms per deciliter, and the renin is suppressed from the kidney. So high aldosterone, meaning the adrenal gland is making more hormone and the renin is suppressed, that is a sign that they may have hyperaldosteronism or too much aldosterone production. and it's very reasonable to send these patients to endocrine. The adrenal sex hormones, unless the levels are high, clearly more than 800 nanograms per deciliter, we can just watch these patients, because sometimes women with PCOS can have high levels of DHEAS, but it's not in the 400 to 600 range, never more than 800. So these are the values to remember, just to make sure as to when we should be concerned about too much production of the adrenal hormones. All right, so this is about adrenal incidentaloma. Now, the second thing I want to discuss is, and again, this is for primary care standpoint. So, just to help the patient, reassure the patient, maybe start the process of a workup before the patient comes and sees endocrinology, and just to make sure if they need to see an endocrinologist or hormone doctor or not. So if the patient is concerned that they're gaining weight and they're very concerned that could it be their adrenal gland? Should their adrenals be looked at? Should we do a CT scan or do the workup? So the first thing I think what we should do as providers is to ask the patient about any steroid use, because excessive cortisol use of any kind can and will lead to weight gain and will lead to all the problems that the steroids cause, which means bruising, difficulty losing weight. They can develop diabetes over a period of time. It can lead to high blood pressure as well. So the most important thing is to ask the patient if they are using any steroids. Now, many patients are on inhalers, steroid inhalers for their breathing issues. Some patients are using creams. In our elderly population, they are getting injections in their knee or hips on a regular basis. And that certainly can contribute, because the steroids, especially injections, they last in the system for a very long time. Some young individuals actually are getting injections in their back, multiple injections over a period of time, and that will cause the problem. So getting good history about any kind of steroid use is extremely important. I've seen some patients who are using, these anisole suppositories, which have steroids on a rather regular basis, and that also can contribute to it. So get a good history about steroid use. Cream, gels, patches, suppositories, all of that, including inhalers. So that's the most important thing, because if they are using steroids, that can certainly cause that. And if indicated, if clinically possible, then cut down, maybe space the steroids a little bit more, or avoid them if they're not helping. Many patients get these steroid injections in their knee, and they tell us that it's really not helping that much. So why not stop and go for maybe knee replacement if indicated. All right, so ask about all steroid use. And I think if we do that, then before we do any extensive workup, and we will discuss the workup here, then we can avoid this unnecessary workup, because if they are getting steroids, then most likely that is contributing to their problems. Now, if you have a patient and you've asked them about the steroid use, and they say that, no, I'm not taking any steroids, and you have once ruled this out, then what are some of the specific features that will suggest or direct your workup towards the adrenal? Because obesity is very, very common. And most obese patients will have some of the features, some of the findings that adrenal or excessive cortisol production will cause. So what are some of the specific things we should look for? Or if we see these findings, that will increase our suspicion of an adrenal producing tumor or a Cushing syndrome in these patients. So these are the patients that I've seen in clinic. So the first important thing I want to highlight here is these stretch marks. So if you see this a stretch mark here, normally anyone who gains weight, women during pregnancy, they will develop a stretch marks, but two things are very important: the color and the thickness of these stretch marks. So if you see here, this patient, this is almost purplish in color, and look at the width of these stretch marks. So they are wide. So sometimes if you measure them, they are about 0.5 to 1 centimeter. If you see stretch marks that have a color like purplish discoloration, and most importantly, if they're wide, very wide, more than 1 centimeter in width, this will increase your suspicion. This should increase your suspicion. But any type of weight gain will lead to some pale stretch marks. So that's the first thing. So look at the stretch marks and measure the stretch marks as to how wide they are. That's the first thing. The second thing is, This hump you see here, this is called the buffalo hump. This is because of the cortisol or steroids will cause abnormal distribution of fat. So they will lose fat from their arms and legs, and it will be deposited in abnormal locations. So in this case, it's getting deposited here on her back, and it's causing a hump. Sometimes it will be accumulated over the clavicle area. So it will cause fullness. And so that's the second thing. Look for this hump, because this is rather common because in patients with excessive cortisol production. And the other thing is this face, the moon-shaped facies. So their face will become more circular. Again, this is because of the abnormal accumulation of lipid in the facial area and around the neck area. So that is also a specific, kind of sensitive sign for excessive cortisol. Either they're taking it or the body is making it and causing these problems. And then the other thing is they have mostly central obesity. So most of the weight gain that they're gaining is in the center of the belly and their arm, and they're losing muscle, and they're losing fat from their arms and legs. So they have thin extremities compared to their central obesity, and most of the weight gain is in the center part of the belly. So if you see these findings on exam, plus it's rather a kind of a rapid weight gain. In the last 1 year, they have gained most of the weight, plus they're having these findings, especially the stretch marks, the hump, the supraclavicular fullness, maybe some bruising, and central obesity with thin extremities. Think about this will increase your suspicion of an adrenal producing tumor. So some of the tests that can be done if you're concerned about it. Once again, you have asked them about any steroid use and they're not using any steroids, then these are some of the tests that can be done. And I just want to discuss this so that these tests can be done correctly. So the first test that can be done is to check the saliva cortisol at midnight. So right before they go to bed, you can prescribe that. They will go to the lab and pick up the cotton swab, which they will wash their hands. Before they brush their teeth, they will use that cotton swab and collect the saliva just before they go to bed. So the important things that the patient needs to know is the timing, just before bedtime. Number one. Number two, make sure that they have washed their hands before they collect the sample, because they're doing it at home themselves. Second thing is, if they are smokers, they should not smoke for at least 3 hours prior to this testing, because that will affect the results. And also they should not brush their teeth, because it can lead to some bleeding, and bleeding can cause the falsely elevated levels. The reason we do this test at midnight is normally the cortisol levels are lowest just before patients go to bed, provided they are not sick or ill or under stress, and they don't do any shift work, because for shift workers, the cortisol levels will be high. So in an individual who works in the morning, goes to bed at night, and does not have gingivitis or any bleeding issues in the gums, this is a very, very good test. It's very convenient as well. We normally do it 2 nights. It can be 2 consecutive nights. It can be, a week apart, but make sure that the patient has good instructions about not brushing the teeth before it. Make sure that they're not sick or ill. And normally the cortisol levels are low at night time. So if you see a low level at night, then that means their body is not making excessive cortisol. And make sure that they don't do any shift work when we order this test. So that is it's very convenient for the patients as well. This test. So that's one way we can rule out or rule in excessive production of the cortisol. So the second test is if they have any of the problems that we discussed, they are smokers or shift workers, then the second test, which is very useful, is a 24-hour urine-free cortisol. So here, the patient will be collecting their urine for 24 hours. As you can see, between the two tests, this is rather not very convenient for the patient, because they will have to stay, home and take their day off and collect the 24-hour urine. So they will get up in the morning, and first you will prescribe this. They will go and pick it up from the from their lab. And they will, when they get up in the morning, they will discard the first urine. They will not collect that urine. And then after that, the entire 24-hour worth of urine will go in that bag, including the next morning, to collect the urine. And then we will see how much cortisol they're producing throughout the day. Again, if there's a tumor, the cortisol production will be high. And we normally look at the levels that are very high, like 2-fold, 3-fold high. And just have the patient eat and drink normally. If they are on medications, you just let them continue the medications that they're on. And so that test will also give us this information if the body is making too much cortisol. And the third test, we already talked about this. Here we give a pill at night just before they go to bed, and in the morning after, we check the levels, cortisol levels in the morning to see how low. Ideally, the level should be low, less than 1.8. If in spite of taking the Decadron or a steroid pill at night, the levels are still high, then that means there is no feedback inhibition and the body continue to make the hormone. And that is where if the levels are more than 1.8, they're 3 or 4 after the Decadron pill, then that is a concern that the body is making too much hormone. So I think if you are suspicious about too much cortisol production, you can start with 1 or 2 tests, and if they come back positive, then that patient needs to be sent to the endocrinologist. But primary care physicians can start the process easily, by giving the patient the correct instruction and most importantly, getting the correct history from the patient. Now, the third and the last part of this talk is adrenal glands and hypertension. Normally, this aldosterone that the adrenal glands, the adrenal cortex make causes sodium retention. If you retain sodium, then this will increase the plasma volume. The blood pressure will increase. And that's why if this benign mass on the adrenal is making too much hormone, then these patients will have high blood pressure. And also this aldosterone dumps out potassium from the system. So most of them, not all of them, will have low potassium or potassium that runs on the lower side of normal, because the aldosterone, the excessive production, is dumping out the potassium from the body. So that's why we always check if we have a young patient who has hypertension, that is difficult to control, and that has low potassium, that increases our index of suspicion for this problem. So this is very important. I think that for primary care physicians, we need to know when should we screen the patients for excessive production of this aldosterone hormone. So any patient, so these are some of the patients that we should think about screening them or checking them for excessive aldosterone. If you have a patient that has sustained elevation of blood pressure is always more than 150 systolic to 100 diastolic on multiple occasions. So there's sustained elevation, especially if the patient is young. We can go ahead and order our aldosterone and renin levels to see if this is the problem. If you have a patient that has resistant hypertension, meaning they are taking 3 or more medications, including a diuretic, and in spite of that, their blood pressures are running more than 140 systolic and 90 diastolic, then it's a good idea to check for aldosterone and renin. If a patient is on multiple medications, so 4 or more medications, and the blood pressure is under control, meaning less than 140 systolic and 90 diastolic, even if the blood pressure is controlled, but they are requiring a lot of blood pressure medications, I think it's a good idea to check for this, because we can give them a specific medication and control and reduce some of the other medications. Any patient who is developing significant hypokalemia or low potassium after starting a diuretic, because again, aldosterone dumps out the potassium from the system, we should consider that. Patient with adrenal incidentaloma, like our patient with hypertension, if they have hypertension and they're found to have an adrenal incidentaloma, it's a good idea to check this aldosterone and renin ratio. Hypertension with family history, if they have a strong family history of strokes at young age, hypertension at young age, less than 40, then that is a good that is an indication to check the aldosterone. And again, patients with family members who have primary aldosteronism, so if the father has the hypertension from primary aldosteronism, and then the family members are developing the same problem, then it's a good idea to check for this condition. So what should we order if we are concerned about it? These are the tests that can be ordered. And the patient does not need to be fasting. In fact, we prefer these tests done sometime 2 to 3 hours after getting up, because that's when the aldosterone production will be peaking. If they are upright for a long period of time, the blood pressure hormones will be high. And again, this is not a fasting test. So if you're seeing a patient in the clinic at 11 in the morning or 10:30, and you are concerned about their low potassium or hypertension at a young age, or multiple medications that are or hypertension that is difficult to control, it's a good idea to check their potassium and order the aldosterone and a renin level. We should look at the list of medications, the kind of medications that they're on. But I will recommend that if you have a high index of suspicion, if there is significant hypertension, please check these levels and don't worry about the blood pressure medications. Check the levels, check the aldosterone and renin and the potassium levels, because if you have a patient who, irrespective of what medications he or she is taking, if their aldosterone is high and their renin is suppressed, even on the medication, this will be a very good screening test for excessive cortisol production. And if you see these values where aldosterone is higher than 10, 11, 14, 15, and the renin is suppressed or less than 1, then I think that's a good time to send the patient to endocrinology to confirm the diagnosis. So again, if you have high index of suspicion, please check. And then if these values are met more than 10 and less than 1, then the patient needs to be referred to endocrinology, hormone doctor, so that we can confirm the diagnosis and then treat this condition appropriately. So just to summarize, the things that I've discussed in the last 40 minutes is the following. The incidentalomas is a radiological diagnosis. The CT scan was done for some reason, and it found this, the patient was found to have this mass. So first thing we need to do is to look at the CT scan before we order any further tests. Get the Hornsfield units to see if it's a benign mass, it's full of lipid. If your Hornsfield units are less than 10, that's good information, and this mass is benign. And then we need to worry about, is this mass secreting any hormones? Is it making cortisol? Is it making blood pressure hormones? And once we have that information, we can start ordering our tests. The best test to rule out cortisol is the dexamethasone suppression test, where the pill is given at night and the cortisol levels are checked in the morning. When the patients are concerned about weight gain, it's always a good idea to ask them about all steroid use. Again, everything, inhalers, including injections, suppositories, everything. Remember, these are specific physical findings which can be seen with excessive cortisol production. We talked about the stretch marks, the wide stretch marks, the buffalo hump, the rounding of the facial features, and central obesity with thin arms and legs. And if you have that index of suspicion, plus they're not using cortisol, you can order a midnight salivary cortisol, a 24-hour urine-free cortisol, or do a dexamethasone suppression test. And if you have a patient, especially a young patient who is on multiple blood pressure medications and is taking those medications and the blood pressures are running high, then you can check an aldosterone, renin, and a potassium level. And remember the values. If the aldosterone is more than 10 and the renin is suppressed, then that's the time to send these patients to endocrinology to make sure that we confirm and make the diet and treat the patient. So that's all I have. And if anyone has any questions, I'll be happy to answer.
Thank you so very much, Dr. Haider. That was a great presentation.
Thank you.
Really smooth, flowed great, and did a wonderful job. We really appreciate all the information you provided. Dr. Paliwal, I see that your hand is raised. Thank you so much. Go ahead for your question.
Thank you for the excellent presentation. I joined midway actually. I have a question. You mentioned 3 testing to check for the excess cortisol.
Yes.
Now, at a primary care level, is there any one test that will really rule in or rule out, or do we need to do all the 3 tests?
So that's a very good question, actually. So it all depends on your index of suspicion. So if you are really not convinced that this is, excessive cortisol production, then I will suggest you start with 1 test. And you can, if the patient can collect a urine reliably for 24 hours. So if you do that test and the patient was able to collect a good sample and your values are low, less than 40, we use a value of 45, and it was a good sample collection. Patient was indeed able to collect for 24 hours. And if the value is low, then you can stop it there. However, if you are concerned that the urine collection was not done appropriately, patient has some urge incontinence, or the urine volume is say 800 or 400, so clearly know that the collection was not good, then you can either repeat that test again with clear instruction or do the second test. So that will be one indication to do a second test. And if your testing shows that the values are high, so the cortisol 24-hour urine comes back 90 or 120, then it's a good idea to repeat the test to confirm that this is a true positive value, and then you will have to do the other two tests. So the second set of tests needs to be done in cases where you have a high value.
Okay, so the 24-hour urinary cortisol is the first test to go for if you have a high index of suspicion.
Well, I'm not pushing for that. You can do a midnight. I prefer midnight saliva testing because it's more convenient for the patient. Because 24-hour they will have to take the day off from work and collect this. So, but if you have a patient who has bad teeth or has gingivitis or is a shift worker, then in that situation the 24-hour urine will become the test of choice. So no one test is clearly superior than other. It depends on their lifestyle and on circumstances, which will dictate which test needs to be done first.
Okay, okay. And in patient with excess cortisol, I mean, don't you think that every time their sugars will show up high or they will show up as a diabetic?
Yeah, absolutely. So they will be at least pre-diabetes or diabetic. But we have seen some cases, some patients, which especially young patients, I mean, they're gaining weight and they don't have diabetes. So, but if they have diabetes or difficult to control diabetes, that will increase your suspicion. But not all patients with Cushing will have diabetes. Their chances of developing secondary diabetes just because of cortisol is higher. But even if they don't have diabetes, that does not rule it out. You still have to measure the levels, the saliva or the 24-hour urine free cortisol.
Okay, okay. Now the next question regarding that aldosterone renin, the thing which you mentioned.
Yes.
Okay, normally I read in the past and I ordered that aldosterone renin ratio. Okay, I mean, is the ratio is more accurate or the individual level is more accurate?
That's again a good question. The ratio is more important actually. So that's why whenever we order aldosterone, we order renin with it. Because if your aldosterone is high, is it suppressing the renin? If the renin is suppressed, then the ratio will go high. So individual value is not that important. The ratio is important. So if you have an aldosterone which is say 20, but your renin comes back as 4, then your ratio is only 5, right? So that is, that does not mean that the patient has primary aldosteronism. But if your aldosterone is high and it's suppressing the level, that is more important. So even if the aldosterone is 10, but the renin is less than 1, then the ratio is going to go up. So ratio is more important. And that's why anytime you order the test, you order both the aldosterone and the renin and calculate the ratio.
Okay, okay. And the last thing is among the things that you mentioned, the indication for checking for aldosterone renin. Okay, I was under the impression if you have a young patient with uncontrolled blood pressure or high blood pressure, that is one of the indication. Okay, is there anything change in terms of like young patient, like in 30s and they come up with blood pressure? I mean,
yeah, you're right. Young patient, and the indication said if the patient is younger than 40, all right. So and they have high blood pressure that is difficult to control. Then certainly that is an indication to make sure that they don't have secondary hypertension like primary aldosteronism. So yes, that is an indication to check it.
okay, and the last thing is if the patient is already on aldactone, when they are difficult to control blood pressure, you sometimes put them on aldactone.
Right.
So do they need to be off aldactone to calculate this, or we can do it?
Yes, so this is a very good practical question, and this is a clinical dilemma. So I will advise you to check it, to still check it, even if they are on aldactone, because aldactone causes renin to go up. But if you get a suppressed renin level on aldactone, this actually will give us more information that the renin should be high, but in spite of the fact that they are on aldactone, provided they are taking it, then the renin is still suppressed. This will tell us that this most likely is primary aldosteronism.
Okay, okay. Thank you so much. I really appreciate.
You're very welcome. Thank you.
Thank you so much for those questions, Dr. Paliwal. This is what it's about. So It's really great that you had some questions for him. And does anybody else have any comments or questions?
I just really appreciate about the incidentaloma, except of course what we get in our area is the radiologists all say, oh, they've got this thing, and even if the Hornsfield units are low, they say, oh, but you really ought to get an MRI.
That is right. Yeah, we see this all the time. Clinical correlation required, maybe do an MRI are the last two lines on the radiology report. Yeah. And this creates a lot of anxiety for the patients. We have seen patients sitting in the clinic and they're really nervous that they have some sort of cancer somewhere. So, yeah, so I agree.
Thank you. Does anybody else have any questions or comments for today's session? All right. If you do, please pass them my way and I'll make sure to get back to Dr. Haidar about them. Our next session will be August 11th, and Justine and Emily will be our guest speakers doing Intro to Diabetes Tech and Carb Counting. So, oh, wait, Dr. Paliwal.
Just a question for the sideline. I mean, you have heard about that new injection for the weight loss that is approved for the Novo Nordisk. I forget the name.
Wegovy. Mm-hmm.
Yeah. Have you started using in the clinic yet, or?
Yeah, so we have prescribed it so far, but I think it's on backlog. So I haven't seen a patient who came back after starting the the higher doses. So I haven't seen the results. It just started. I think we started prescribing it in July. But I'll tell you this: this is same thing as Ozempic, like semaglutide. We have a few patients that we ask them to use 2 injections. So instead of the 1 milligram dose, they are already using the 2 milligram dose. And there is superior weight loss, significant weight loss. So I have no doubt that this higher dose of 1.7 or in 2.4, there will be weight loss. And in the clinical trials, there was up to 30 pounds weight loss in the first 6 months. So that is excellent. I'm not surprised. In fact, last time when I had done this session, we talked about a medication, tirzepatide, which is a combination of 2 different incretins, GLP or your Ozempic, and a GIP, which will be coming out, I think, earlier next year. And I think that will also gain FDA approval for weight loss along with diabetes. And the weight loss is even better with that medication as compared to your Wegovy. So there are more medications in the pipeline. So the last medication for weight loss was approved in 2013. So after a hiatus of about 8 years, this is the first medication that is approved. So I think more incretins will actually be available to us for weight loss in the future. So.
Okay, thank you.
Thank you so much. All right, well, you guys will get about 7 minutes back to your day. I really appreciate your presentation, and thank you so much for the good questions and comments, and I'm hope to see you guys soon. Have a great rest of your week. Bye.
Thank you.